So, in the last session, we talked about the morphology of the pulp and the functions and structures of the pulp dentin complex. Today, I would be discussing about another important aspect that is related to the basic of endodontics, that is the tooth anatomy. And we'll talk about the tooth anatomy and the root canal configurations. Okay. So let us start. We'll talk about the tooth morphology first. Okay. See, whenever we talk about the tooth morphology related to the subject of endodontics, we know that the apical one-third of the root is typically more important for the endodontic procedures. So we'll firstly discuss the apical one-third anatomy of the root. If we look at the longitudinal section of any tooth root, its anatomy is something like this. Okay, this is longitudinal section of a tooth root. And there are three important landmarks that are present in the apical one-third. Okay, this narrowest apical portion of the root canal, this is called apical constriction or AC. It is also called minor diameter of the tooth. It is the most constricted apical part of the root canal. That is called AC or apical constriction or minor diameter. Then the terminus of the root end, it is called the AF apical foramen or the major diameter. Okay. First anatomic landmark is the apical constriction or the minor diameter. The second anatomic landmark is apical foramen or the major diameter. Okay. And the third anatomic landmark is CDJ, that is cemento dentinal junction. It is cemento dentinal junction. Basically speaking, this cemento dentinal junction is a histological landmark. It is an apical termination of the pulp and the beginning of the PDL. Okay. See, in the root canal, there is pulpal tissue. When the pulpal tissue ends somewhere near the apical constriction and apical foramen, there is beginning of the PDL. So what is cemento-dentinal junction? It is the termination of the pulpal tissue present in the root canal and beginning of PDL in the prodontium. So basically the junction of the pulp and the PDL is known as cemento-dentinal junction. So this is a histological landmark. Histological landmark means it can be only seen in the cross sections of the tooth studied under microscope. It is not visible clinically and definitely not visible on the radiograph. So in the anatomy of the root apex, there are three important landmarks: the apical constriction, apical foramen, and the CDJ. Since root canal procedures are done in the root canal space, that is the pulp treatment is done, this CDJ is the ideal landmark. It is considered to be the ideal or the optimal landmark for the termination of root canal procedures. But the problem is that we cannot determine it clinically or radiographically. So apical constriction is considered to be the best practical landmark. For what? For apical termination of root canal procedures. What is the meaning of root canal procedures over here? Root canal procedures means the procedures like your working length determination, cleaning and shaping, and obturation should ideally terminate at CDJ. But CDJ is not possible to be determined clinically and radiographically. So what is the next best practical landmark? The next best practical landmark is the apical constriction or the minor diameter that is present. Now, if we come back to the schematic diagram that I've drawn, if we look at the space that exists between the apical constriction and the apical foramen, okay, there is a fan-shaped space that exists between the apical constriction and the apical foramen. This space that exists between apical constriction and apical foramen has been defined as the shape of the space that exists between the apical constriction and apical foramen is defined as parabolic in shape. Okay, parabolic. It is also called funnel shaped. The funnel shaped space that exists between the apical constriction and apical foramen, and shape of morning glory. Morning glory is basically a flower. So there are three terms that are used to define the shape of the space that exists between the major and the minor diameter. We call it either funnel shaped, morning glory, or sometimes instead of parabola, a better term would be a hyperbolic in shape. Hyperbolic in shape. Okay. These are the three terms that are used to define the shape of the space that exists between the apical constriction and the apical foramen. Now, if we look at the dimensions and the positions of these landmarks, then apical constriction is on an average 1 to 1.5 millimeter coronal to apical foramen. The minor diameter is 1 to 1.5 millimeter coronal, means above the apical foramen in the root canal. If we talk about the CDJ, CDJ is usually in the range of 1 millimeter coronal to apical foramen. And I have already told you that CDJ is considered to be the ideal or the optimal landmark for the termination of root canal procedures. So if we look at the average dimensions, we can see that CDJ nearly coincides with the apical constriction, and that's why apical constriction is considered to be the ideal practical landmark for the termination of root canal procedures. Now, if we look at the radiographic appearance of the tooth root on an X-ray, we are not able to identify the apical constriction. But what we see is termination of the root end. There would be a root canal and there would be termination of root end. This tip or end of the root is called vertex. The highest point in the termination of the root is called vertex. And if we look at the anatomical details, that apical foramen or the major diameter is somewhat located off center from the root vertex. Okay, this is the position of your apical foramen. Apical foramen or the major diameter is not always located at the root vertex or the termination of the root. Majority of the times it is located off center. How much it is off center? It is off center or off vertex by 0.5 to 3 millimeters. It would be located somewhere below. Okay. Only in 15 to 46% cases, I am discussing the apical root anatomy. It coincides with vertex. In only 15 to 46% of the cases, the apical foramen would be located bang at the termination of the root or the root vertex. So more than 50% of the cases, it is off center. And how much it is off center? It is off center by 0.5 to 3 millimeter. Okay. And that is the reason that the termination of the root canal procedures, that is the working length determination, the cleaning and shaping, and obturation, should ideally terminate slightly short of the root apex that we see on the X-ray. Because if we are going to the root apex, we are most likely going beyond the apical foramen, as apical foramen is slightly short of the anatomic root apex. So this is the conceptual thing. Whenever we'll discuss about the working length, the clinical relevance of the position of apical foramen with respect to the root end would be more relevant to you. Okay. Right now, I am discussing the anatomy of the root apex, and I have discussed three features, that is the apical constriction, the apical foramen, and the CDJ. Now, section of the root. Cross section of the mid root. Till now, we have seen the root and in longitudinal section. If we look at the cross section of the mid root, the fourth anatomical feature that is found is called isthmus. Isthmus. Isthmus is also called anastomosis. Isthmus is a connection, the structure called isthmus or anastomosis. Now, Kim gave the classification of isthmus into 5 types. These anatomical features and details, they form the basics, and they are quite important as far as your examinations are concerned. In the recent years, there have been the trend that majority of the questions are related to the basics of the subjects. Okay. So what is the definition for isthmus? If we have to define what is an isthmus, isthmus is a narrow ribbon-shaped space between two or more canals that contain pulp or pulpally derived tissue. This is the technical definition for an anatomical landmark called isthmus, pulpally derived tissue. Okay. It is a narrow ribbon-shaped space between two or more canals that consist of pulp or pulpally derived tissue. Hope the connection is okay. Let me check the connection once. It looks okay from my side. Okay. Now we'll see the classification of the isthmus. The isthmus type 1. It is an incomplete connection. Incomplete isthmus between two canals in a root. I hope you are getting the connection. Hello. Okay. So if you look at the cross section of the root, there would be two canals with an incomplete connection between them. It's called type 1 isthmus, a narrow ribbon-shaped space. Type 2 isthmus is a complete connection. It is a complete isthmus between, again, two canals. Okay. Means there would be two canals with a well-defined and complete connection between them as type 2 isthmus. whether the connection is proper or not. Okay, fine. So a complete isthmus between two canals is called type 2 isthmus. The, continuing the classification, the type 3 isthmus. The type 3 isthmus is a very short but a complete connection. A very short and complete isthmus between again two canals present in a root. So there would be a cross section of the root. A single root has got two closely spaced root canals, and a very short but complete connection between them is called type 3 isthmus. Okay. Type 4 isthmus is a complete or incomplete connection. It is a complete or incomplete connection between three or more canals. In single root of any tooth, when we look at the cross section, there would be three or more canals with complete or incomplete connections. Some connections would be complete, some connections would be incomplete. It is known as type 4 isthmus. And finally, type 5 isthmus means there are two or three canals without visible connections. But there are no visible connections in the cross section of the mid root. So root of any tooth, if we look at, there would be two or three canals without visible connections. These are the classification of isthmus as given by Kim into 5 distinct types. And what is an isthmus? It is a connection, narrow ribbon shaped space that exists between two or more canals in a single root of any tooth. So these are the 4 important anatomic landmarks that we have to consider: the apical constriction, the apical foramen, the CDJ, and the isthmus. Now we talk about the root canal system. We talk about the root canal system. If we look at the root canal system of any tooth, it consists of two parts. Suppose this is a mandibular molar. It would be having a root canal system like this. So the first part of the root canal system consists of the pulp chamber. That is the coronal part of the root canal system. And the second part is the radicular pulp. These two together constitute the root canal system. So for any particular tooth, if we have to study the root canal system, we'll be talking about the pulp chamber and the radicular portion of the pulp. And from the clinical perspective, it is the radicular portion of the pulp that is more important. So if we look at the radicular pulp in an enlarged form, okay, so this would be having a root canal like this. In the apical 1/3, it divides into branches like this. Okay. It constitutes apical delta. This is the primary canal, and it constitutes apical delta. If we look at the branches of this apical delta and number them 1, 2, 3, and 4. Just to illustrate, I have drawn 4 branches of this system numbered as 1, 2, 3, and 4. If we look at these branches, then branch number 1 and branch number 4, okay, it does not communicate with Periodontal ligament means the primary root canal is dividing into several branches in the apical one third, and they together constitute what is called the apical delta. Okay, out of the several branches of the primary root canal, some branches do not communicate with the PDL. To illustrate in the diagram, I have drawn the branches number 1 and 4 do not communicate with the PDL, and these branches they are called apical ramifications. On the other hand, branches like branches 2 and 3, that are the branches that communicate with PDL. They connect the primary canal to the periodontal ligament. And the branches of the primary root canal that communicate with the PDL, they are called accessory canals. So these are the two terms that are used for the branches of the primary root canal. Apical ramifications are those branches of the primary root canal that do not communicate with the PDL. On the other hand, accessory canals are those branches of the primary root canal that communicate with the PDL. These accessory canals are known by other names also, like lateral canal or furcation canals, depending upon their location. Furcation, as the name indicates, they would be present in the furcation area of the multi-rooted teeth like mandibular and maxillary molars. Lateral canals would be present in the coronal or middle one third of the root canal, and accessory canals are most common in the apical one third of the root canal. Okay. So you should understand technically what is the meaning of apical ramifications and what are accessory canals. Now, if we look at the distribution of accessory canals, if we look at the distribution of accessory canals, then the root can be divided into three portions: the apical one third, the middle one third, and the coronal one third. Coronal, middle, and apical one third. So the majority or the maximum accessory canals, 74%, they are present in the apical one third of the root canal. Okay. 15%, they are present in the cervical portion of the root canal. And 11%, they are present in the middle one third of the root canal. Okay. So we can see that maximum percentage of accessory canals is present in the apical one third, and minimum percentage of accessory canals is present in the middle one third of the root. These are the general terms. Whenever we talk about the anatomy of the root canal system overall for any tooth in the oral cavity, what are accessory canals, what are apical ramifications, and what is the distribution frequency of accessory canals, I have told you. Now, if we talk about one particular tooth, that is first mandibular molar. Okay. Then it has got three patterns of accessory canals. Now I'm talking about a particular tooth, that is mandibular first molar. It has got three patterns of accessory canals. This is a mandibular molar. It would be having a root canal system and the distal side. Okay. This is an accessory canal. Okay. There would be a single furcation canal. Furcation canal means canal, accessory canal present in the bifurcation or trifurcation area of multi-rooted tooth. This is present in 26% cases of mandibular first molar. If we look at the other pattern, this is a mandibular first molar. Again, this is its root canal system, the mesial side and the distal side. It would be having an accessory canal like this. there would be a single lateral canal. What is a lateral canal? Is present in the coronal or middle one third of the root. What is a furcation canal? It is an accessory canal present in the bifurcation and trifurcation area of the multi-rooted tooth. In 13% cases, it would be having a single lateral canal. And in the third scenario, if this is a mandibular molar, the mesial side and the distal side, this is its pulp canal, a root canal system. It would be having both furcation canal and a lateral canal. That is present in 10% cases. In 10% cases, they have got both furcation and lateral canal. Okay, let me check. Don't let me check. Someone has said that it is not visible on the screen. Is it okay now? I hope it should be okay now. So what I am telling you, I am telling you the pattern of accessory canals for the mandibular first molar, and we have talked about that three patterns of accessory canals are present for mandibular first molar. In 26% of the cases, there is a single furcation canal, means there will be an accessory canal, as I've shown in the figure marked with red. In 13% of the cases, there is a single lateral canal. And in 10% of the cases, there is both a furcation and a lateral canal, as can be seen in the figure. These are the three patterns of accessory canals that are present in the mandibular first molar. Previously, what I have told you about the distribution of accessory canals. Location, maximum number of accessory canals, 74 to 76% are present in the apical one third of the root. In the cervical or the coronal one third of the root, 15% of the accessory canals are present. And in middle one third, the minimum number, that is the 11% of the accessory canals are present. So maximum in the apical one third, minimum in the middle one third of the root, the distribution of accessory canals. Okay. Now, these are the general things about the anatomy of the root apex, the important anatomical structures like apical constriction, foramen, and the CDJ, and anastomosis or isthmus. And then we have talked about the root canal system, the accessory canals, what are apical ramifications, what are accessory canals. Now we'll talk about the root canal configurations. Root canal configurations. To understand the root canal configuration, over the years, various classifications have been given. But from your perspective, two important classifications are the Wien's root canal configuration and Vertusi's root canal configuration. Vertusi and Wien's root canal configurations. Okay. According to the Wien, there are 4 types of root canal configurations. According to Vertusi, there are 8 types of root canal configurations. It would be better if we see them side by side so that you are able to understand the differences between them and what do they actually represent. So Wien divided it into type 1, type 2, type 3, and type 4 root canal configurations. According to Wien, type 1 is a single canal in a single root of a tooth, represented as 1. Okay. Type 2 is a configuration. There would be two orifices, two canals emerging and converging into one. That is called 2-1 configuration. Okay. Veins type 3 is a two canal configuration. In root of a single tooth, there would be two separate canals exiting as two separate apical foramen. And finally, according to vein type 4 is a 1-2 configuration. There is a single orifice, single canal originates, divides and exits as two apical foramen. That is called 1-2 configuration. 1, 2, 1, 2 and 1-2 configuration veins type 1, 2, 3 and 4 canal configurations. Now we look at the vertice canal configurations. According to vertice, type 1 is basically the same as the vein that we have seen represented as 1. In a single root of a tooth, there is a single canal from coronal to apical 1/3. According to vertice, type 2 is a 2-1 canal configuration. 2-1 canal configuration. There are two canals coronally that unite and exit as 2-1 canal configuration. According to what you see, the type 3, it is a 1-1 canal configuration. Means coronally there would be one canal, it divides into two and they join together and exit as 1. This is known as 1-1 canal configuration. What you see, type 3 canal configuration. According to what you see, type 4 is a 2 canal configuration. Represented as 2 means into root of a single tooth, there would be two separate canals exiting as two separate apical foramen. According to what you see, type 5 is a canal configuration that is 1-2 canal configuration. Single orifice, single canal originates, it divides into two and exit as two. That is 1-2 canal configuration. According to what you see, type 6, it is 2-1-2 canal configuration. 2-1-2 means there would be two orifices, two canals, they unite and they again divide and exit as two canals. So coronally there are two orifices, they join together somewhere in the middle 1/3 of the root, they again divide and exit as two separate canals in the apical 1/3. Okay, according to what you see, type 7, it is represented as 1-2-1-2 canal configuration. Okay, so in the root of any tooth, coronally there is a single orifice, a canal originates but divides into two, they join together, then again divide and exit as 2. 1-2-1-2 canal configuration. Okay, quite a complex root canal anatomy is there. And finally, according to what you see, type 8 is represented as 3, means in root of a tooth, there would be 3 orifices through which 3 separate canals originate and terminate as 3 separate apical foramen. So what we learn from these canal configurations, it is not necessary that a tooth root has got a single apical foramen. It can have multiple apical foramens depending upon the root canal configuration. So please do not get confused between the two type of classifications, veins and vertices. Some of vein and vertice type 1 and type 2 are same, and then there is a difference in the classification. This is how you have to remember the been in the vertices classification of the root canals. Okay. Okay. Now we talk about these are in general. And if we talk about any particular tooth, it is the maxillary second premolar. It is maxillary second premolar that has depicted all possible 8 vertice configurations. All the possible 8 types have been depicted by which tooth in the oral cavity? The maxillary second premolar. It has shown all possible 8 vertice canal configurations. Now we talk about individual root canals, individual teeth canal systems. Whatever we have talked about till now is generalization of the distribution of the root canals and their configurations. Now we talk about mandibular. If we look at mandibular incisors as a group of teeth, they consist of 2 types of incisors, definitely a central incisor and lateral incisor. Okay. Majority cases, in majority of the mandibular central incisors, they have got a single root and a single canal. Okay. More than 70% cases. In nearly more than 70% cases, there would be a single root and a single canal. So what is the most predominant vertice type of root canal present in a mandibular incisor? It would be type 1, according to what you see. Isn't it? Single root with a single canal. But in 22 to 40% cases of mandibular incisors, there are 2 canals. The root is single, but there are 2 canals. If we look at the tooth in buccolingual section, the tooth would be something like this, with 2 canals, a orifice, 2 canals, and they join together and exit as 1. 1, 2, 1 configuration. This is the buccal side. This is the lingual side of a mandibular incisor. So the question is asking you, what is the incidence of 2 canals in a mandibular incisor? Answer would be 22 to 40% cases. The question is asking you, what vertice configuration is present in cases of 2 rooted or 2 canal mandibular incisors? It is vertice type 3 configuration. That is 1, 2, 1 configuration. There would be a single orifice, a lingual and a buccal canal, and they join together and exit as 1. 1-to-1 configuration. So in cases of 2 canal forms, it is the type 3 configuration that is most common. Otherwise, the type 1 overall is most common for mandibular incisors, but in 2 canal versions, the type 3 is the most common configuration, and the incidence of 2 canals is 22 to 40%. Okay. Another question is incidence of 2 canals is for central greater than lateral incisors. Okay. This can be confusing at times when you look at the MCQs from different books, because there are 2 predominant texts available for endodontics, that one from Engel, one from Cohen. If we look at the Engel's data, it says that the incidence of 2 canals is more in mandibular lateral incisor than central incisor. If we look at the data from Cohen, it says that the incidence of 2 canals is more in central incisors as compared to lateral incisors. Both of them are contradictory. So please do not get confused. You have to stick to this data, that incidence of 2 canals is more for central incisors as compared to lateral incisors. And what is the overall incidence of 2 canals for mandibular incisors? 22 to 40%. And what is the vertice configuration present in two canal forms. It is type 3, that is 1-to-1 canal configuration. Now we talk about mandibular canine. Mandibular canine has got the highest incidence of two canals amongst all anterior teeth. Amongst all anterior teeth. If we talk about the incisors and the canines, the maxilla and the mandibular combined together, the highest incidence of two canals would be for mandibular canine overall. Okay, these are the anterior teeth most likely to show more than one canal of all anterior teeth. Now we talk about mandibular first premolar. Mandibular first premolar has the highest incidence of atypical canals or two canals amongst all teeth. Not only the anterior teeth, but anterior and posterior taken together. Amongst all teeth present in the oral cavity, which tooth has got the highest incidence of atypical? Atypical means apart from the usual anatomy. The number of roots, the number of canals can be highly variable in cases of mandibular first premolar. And because of such high variations, they are also called endodontists' enigma. These teeth are called endodontist's enigma. Enigma is an English term that means something that is puzzling, a constant source of trouble. Okay, so because of the presence of highly variable root canal anatomy with mandibular first premolars, okay, they are called endodontist's enigma. So they have the highest incidence. Look at the question carefully, whether it is asking you about the overall teeth or it is asking you about the anterior teeth. If for the anterior, it would be mandibular canine. If for overall in the oral cavity, it would be mandibular first premolar, not the second premolar, first premolar. Okay. Mandibular premolar usually is a tooth with a single root. Okay, it can got an accessory root. Not only the root canal configuration, the root number can also be present extra in cases of mandibular premolars, especially for first premolar. The accessory root of a mandibular premolar, it is called Tome's root. This extra root of mandibular premolar, it is called Tome's root. Okay. These are the variations in the root and the canal anatomy of mandibular premolars. We talk about mandibular first molar. Mandibular first molar is usually a tooth like this. Okay, it is a two-rooted tooth, a mesial root and a distal root. Mesial root is usually curved and the distal root is straight. Two roots with three canals. So usual picture, a normal picture is two roots and three canals. The three canals are the mesiobuccal canal, the mesiolingual canal, and the distal canal. This is the usual picture of a mandibular first molar, majority of the cases. If we talk about the variations, then the first type of variation is extra root. Extra root of mandibular first molar. This extra root can be located either on the mesial side or it can be located on the distal side of the tooth. Extra mesial root, extra distal root. So there can be a mandibular molar with an extra mesial root like this. There can be a mandibular molar with extra distal root like this. Most of the time, this extra mesial root is located on mesiobuccal aspect. Extra mesiobuccal root. And this extra mesiobuccal root is called RP or radix paramolaris. What is the term given to the extra mesiobuccal root of mandibular first molar? RP is a standard abbreviation. It is called radix paramolaris. When the extra root is present distally, it is mostly on the distolingual aspect. It is an extra distolingual root and it is called RE, that is radix entomolaris. So there are two terms used for the extra root of mandibular first molar: radix paramolaris, located on the mesiobuccal aspect, and radix entomolaris, located on the distolingual aspect. If we talk about the incidence, then the incidence of radix entomolaris is greater than radix paramolaris. This incidence also shows ethnic variation. Ethnic variation. Ethnic means human beings belong to different ethnicity. So the incidence of extra root, radix entomolaris and paramolaris, is more in Asians as compared to Caucasians. Who are Caucasians? The whites, the North Americans. Asians, we are Asians. So the incidence of radix extra root is more in Asians as compared to Caucasians. These are the variations in the number of roots. The second variation can be in the number of canals. Okay, there can be an extra mesial canal and an extra distal canal. Okay, normally we look at the tooth from above. Tooth has got canals like this: the mesiobuccal, mesiolingual canal, and the distal canal. Three canals of a mandibular molar. Extramesial canal usually present between the two mesial canals and it is called mid-mesial canal or canal, abbreviated as canal. It has an incidence of 1 to 15%. Extra distal canal means instead of one, there would be two distal canals, and this is an incidence of 30%, quite high. Mandibular first molars have a 30% incidence of extra distal canal. So these are the variations in the number of roots and canals for mandibular first molar. The next tooth would be mandibular second molar. This tooth has an important variation in the root canal configuration that is called C-shaped canals. C-shaped canals. Okay. C-shaped canals is the configuration of root canals seen clinically based upon the shape of the root canal orifice. This was initially identified by Cox and Cook. C-shaped canals were first identified by Cox and Cook, and they are classified into three types. This classification was given by Selzer and Melton. I am talking about the anatomical variations with the individual group of teeth. Currently, we are discussing mandibular second molar. An important anatomic variation in the root canal configuration is the presence of C-shaped root canals that were first identified by Cox and Cook, and it was classified into three types by Selzer and Melton. Type 1 C-shaped canal is a continuous C-shaped orifice. If we look at the pulp chamber of a mandibular second molar, instead of different orifice, we would find one continuous C-shaped orifice from mesial to the distal is known as type 1 C-shaped canal. We would not find separate canals, but from mesial to distal, there would be a complete continuous C-shaped orifice. Type 2 C-shaped root canal is a semicolon shape. It is a semicolon shape of the canal. Means if we look at the floor of the pulp chamber after doing excess cavity preparation, we would see one single orifice and a C-shaped orifice. So the anatomy of the orifice is somewhat semicolon shape. One continuous C-shape and one separate canal. Semicolon shape. Okay. Type 3 C-shaped root canals. 2 or 3 orifices are present, but they are arranged in form of C. Means they would be arranged in the form of C. 2 or 3 separate orifices would be present. Okay, arranged in the form of C. Without going into the necessary details, just remember that whenever we geometrically define these C-shaped root canals, then we talk about 2 alpha and beta. For type 2 C-shaped root canals, both the angles are greater than 60 degrees. Sorry, either angle is greater than 60 degrees. And for type 3 C-shaped root canals, both the angles alpha and beta, both, they are less than 60 degrees. Okay, just remember this additional thing, 2 and alpha and beta. But what is the principal basis for classification? Depending upon the shape of the orifice, it is semicolon shape for type 2 and 2 or 3 separate orifices are present arranged in the form of C. Fan and fanned, okay, they gave 2 additional types. I'm talking about the classification of C-shaped root canals, which are most common in mandibular second molars. 2 additional types were given. Type 4. There is a single orifice in center of C-shaped groove. In the center of C-shaped groove, there is a single orifice. So if we look at the floor of the pulp chamber, there would be a groove and a single canal orifice is available in the center of the groove. And finally, type 5 C-shaped root canal. There is a C-shaped groove, but there is no canal orifice in the coronal area. So in the floor of the pulp chamber, we would just see a C-shaped groove. No orifice is visible. These are the C-shaped root canals. If we talk about the incidence of C-shaped canals, then it has got highest incidence in, mandibular second molars. Highest incidence of C-shaped root canals are present in mandibular second molars. If we talk about the maxillary teeth, maxillary incisors and canines, they have got very less incidence of atypical root canals. That's why we have already seen that mandibular canines have got the highest incidence of multiple root canals in cases of anterior teeth. The mandibular first premolar has the highest incidence of atypical canal amongst all teeth in the oral cavity. Variations would be there in maxillary premolar. The usual picture of maxillary first premolar is, it is a two-rooted form, a buccal and lingual root and it has got two canals. Usual anatomy. If we talk about variations, then the variations would be three root three-rooted maxillary first premolar, and the incidence of three roots is 6%. Okay, the incidence of three roots is 6% for maxillary first premolar. Then we talk about maxillary first molar. Maxillary first molar, usually it is a tooth with three roots and three canals. Okay, the tooth is something like this. Okay, it is a maxillary molar, a mesiobuccal root, distobuccal root, and the palatal root. These are the three roots, and correspondingly, there would be three canals in the tooth. If we talk about the variations, there can be an root, and most of the time there is an extra palatal root with a reported incidence of 1 to 4%. Means instead of a single root, there would be two palatal roots. And just like mandibular first molar, the location of this extra palatal root can be on the mesial side or on the distal side. So there can be a maxillary molar like this, a mesiobuccal root, a palatal root, and an extra palatal root on the mesial side. Or there can be a maxillary molar with anatomy like this, the mesiobuccal root, the regular palatal root, and an extra palatal root on the distal side. So depending upon the location, it is called RML and RDL. The extra root is called RML and RDL, that is radix mesiolingualis. Okay, the extra root of maxillary first molar, and it is called radix distolingualis. And I'm again stressing that whatever these abbreviations I've given you are standard abbreviations. They can be quoted as such in the questions and in the options. RE, RP, RML, RDL, MM canal, like this. Okay. Radix mesiolingualis and radix distolingualis. The second anatomic variations can be in the number of canals. Number of canals. The most important anatomic variation is an MB2 canal, which is also called mesiopalatal canal. Okay, abbreviated as MP canal. So please do not get confused. MB2 canal is also called mesiopalatal canal or MP canal. It has an incidence of greater than 90% for maxillary first molar. More than 90% of the cases it will be present. And if we look at the maxillary first molar from coronal aspect, the mesial side, distal, buccal, and the palatal side of the tooth, this is your MB1 canal, this is distobuccal canal, this is palatal canal, mesiobuccal, distobuccal, and the palatal canal, and the MB2 canal or mesiopalatal canal is located somewhere here. This is MB2 canal or mesiopalatal canal. So if we connect them with three imaginary lines, you can see the location of the MB2 canal is mesial and palatal to the principal mesiobuccal canal. That's why it is also called mesiopalatal canal, because it is located mesially and palatally to the line joining the mesiobuccal and the palatal canal. average distance between MB1 and MB2 canals is nearly 2.24 millimeters, the average distance. And the location is mesially and palatally to the MB1 canal. The second variation can be an extra distobuccal canal. Instead of single, there would be two distal canals. This is an incidence of 1 to 9%, very less as compared to MB2 canal, and mostly they have got a single orifice. Unlike the mesial canals that have got two separate orifices, the MB1 and MB2, most of the time the two distal buccal canals would be having a single orifice 1-2 configuration. Okay, so incidence of 1 to 9%. These are the important anatomic variations in the root canal configurations for the different groups of teeth in the oral cavity. Okay, I hope today's session has been comprehensive enough and you have been able to understand the anatomy of the root apex, the root canal systems, what are accessory canals, what are apical ramifications, what is the distribution, and then the individual variations in the different groups of teeth. Okay. With that, I'll conclude today's session. See you again in another interesting session about the subject of cons and endo. Till then, keep reading. Thank you very much for being connected with us. Good night, everyone. Okay.